This is Dr. Stephen Harris. Pharmacology Section 6 is going to be drugs of inflammatory and related conditions. In Chapter 1, we're going to talk about histamine and the various antihistamines. Let's start by looking at the properties of histamine. Histamine is an autocoid. It's found in high levels in the lungs, in the skin, and also in other places in the body. It's released from mast cells and basophils, and certainly we think about histamine and its involvement in type 1 hypersensitivity reactions. We've seen a number of drugs that can cause histamine release. Examples of those drugs are things like morphine and amphotericin B. We've also talked about vancomycin's histamine reaction that we talked about as red man syndrome. Histamine works through a couple of G protein linked receptors, which we'll talk about on the next couple of slides. Most of the effects of histamine in the body are mediated by binding to histamine H1 receptors. So when you think about H1 activation, you get vasodilation through the formation of nitric oxide. You might remember that back in the cardiovascular section, we looked at a diagram in the chapter on angina drugs, where we looked at activation of histamine receptors being directly coupled to nitric oxide synthase. Nitric oxide synthase, the enzyme that converts arginine to citrulline and releases nitric oxide, which causes vasodilation. This leads to increased capillary permeability and edema. H1 activation on smooth muscle cells causes smooth muscle contraction because H1 receptors are GQ coupled. It's also the H1 receptor that's responsible for the pain and itching associated with histamine release. The H2 receptor is more limited in terms of where it's found. Mostly think about H2s on parietal cells. When stimulating these receptors, you get an increase in gastric acid secretion that could lead to GI ulcers, making this receptor a target for peptic ulcer medications. In this chapter, let's focus specifically on the blockers of histamine H1 receptors. All of these drugs are competitive antagonists. Certainly they're going to vary in terms of their pharmacologic and kinetic properties, and these are summarized on the upcoming table. We divide the antihistamines into first-generation and second-generation drugs. In fact, I'm going to take you to the second-generation drugs at the bottom of the table, and let's discuss them first. The drugs cetirizine, loratadine, and fexofenadine are all second-generation drugs. And you should start by learning the advantages of second-generation drugs. The second generations are less likely or very unlikely to enter the CNS, and as a result, they're going to be much less sedating compared to first-generation drugs. In fact, that is such a big advantage, I think it makes for an excellent test question. A second property of second-generation drugs that will distinguish them from first-generation is that the second generations don't block muscarinic receptors. All of the first generations have some anti-muscarinic effects that could result in things like constipation, dry mouth, or even tachycardia. So the two advantages, the lack of CNS entry, less sedating, and no muscarinic block for second generations. But when you look at the first generation drugs, the prototype is diphenhydramine, probably a drug that you know, probably even a drug that you've taken at some point in your life. Diphenhydramine can block muscarinic receptors. It certainly has the sedative effects, and it even has anti-motion sickness effects, indicating its ability to effectively get into the CNS. But when would be a time that you would want the sedating effect from this type of drug? Clearly, folks occasionally need help getting to sleep, so the sedating effect could be useful. We talked about second generations not causing drowsiness, but at times you might actually want a drug to help you sleep. Promethazine, chlorpheniramine, and meclizine are other first-generation antihistamines. In particular, note the anti-motion sickness effects of meclizine. It's a pretty effective antiemetic, as is promethazine, which is also commonly used for that purpose. When you review the uses for the histamine H1 blockers, I want you to think about whether or not it's a first-generation effect, a second-generation effect, or perhaps both. When it comes to treating allergies, either first or second generation drugs can be useful. But if you're going to use one of these drugs for motion sickness, it has to be first generation. For nausea and vomiting, it has to be a first generation drug. In fact, meclizine is useful for nausea and vomiting in pregnancy. For preoperative sedation, that's a first generation. Over-the-counter sleep aids, that's first generation, but if it's a antihistamine found in a cold medication, either a first or a second generation drug would be useful. For Parkinson's disease, we take advantage of the fact that first generation drugs block muscarinic receptors, which has some benefit in either Parkinson or acute EPS. In both cases, you see increased levels of acetylcholine, and thereby blocking muscarinic receptors is helpful. There's not much to add to the side effects of the H1 blockers that we haven't already covered. When we think about the sedative effects of the first generation drugs, again, that could be a benefit or that could be something that patients would complain of. Also with muscarinic block, that's a property associated with the first generation drugs. So remember, a complaint of dry mouth would be associated with a first generation drug due to muscarinic block.